Hello, everyone. Thank you so much for joining. We apologize for the delayed start. We're having some technical difficulties, but thank you very much for being here. We will just give another moment for some more people to join, and then we'll go ahead and get started.
I have the WeTransfer codes.
Oh, perfect.
Wait.
All right. So good morning, good afternoon, everybody. Thank you so much for joining again. Apologies for the delayed start, but we welcome you to today's webinar, which is hosted by Hepatitis Delta Connect of the Hepatitis B Foundation. My name is Beatrice Sovich. I'm a public health program manager at the Hep B Foundation and the manager of Hepatitis Delta Connect program. Thank you all for being here today. Today's webinar is focused on the work and research of Dr. Thomas Vanwolleghem, who will be presenting some of his extensive research about the long-term health outcomes of hepatitis delta based on studies that he has conducted in multiple settings and in a global context. Dr. Vanwolleghem will share about his work with the Hepatitis Delta International Network and will speak to the urgent need to advocate for improved education about HDV infection and increased access to approved treatments. We're very much looking forward to a great presentation. Next slide, please. Thank you so much. So before we begin, just a brief note about participating in the webinar. So I'd like to remind all participants that during the webinar, all audience members are muted. We encourage you to use the chat feature to let us know who you are and where you are joining from. And if you have any technical challenges, please indicate your issue using the chat box and we will address it as soon as possible. At any time during the presentation, you can enter questions into the Q&A box. Questions will be addressed by Dr. Vanwolleghem at the conclusion of the presentation, and the session is also being recorded, and slide presentations will also be shared following the webinar. Next slide, please. Thank you. So just a brief background about our Hepatitis Delta Connect program. So Hep Delta Connect is a dedicated program of the Hepatitis B Foundation, which was established in 2016 for the explicit purpose of raising awareness about hepatitis delta and promoting diagnosis, screening, research, and linkage to care, as well as providing support for people living with and affected by hepatitis delta through a variety of channels, including email and phone consults, social media, newsletters, blog posts, a frequently updated website, fact sheets, focused advocacy, and webinars such as this one. We also run hepatitis delta focused events and lead Hep Delta public health research projects. We are hoping to continue to build and expand our programming throughout 2025 and in the years to come, and we will keep you posted about these developments and further opportunities to get involved. Next slide, please. Thank you. So today we are very excited and honored to be joined by Dr. Thomas Vanwolleghem, who is a professor and clinical researcher at the University of Antwerp. His research aims to study, guide, and improve clinical outcomes of patients who are living with viral hepatitis by analyzing morbidity and mortality and pathophysiology at a clinical and cellular level with clinical trials, patient registries, and translational approaches to well-characterized patient samples, both from liver and blood. And he also examines the cascade of care in patients with chronic hepatitis B and C infections by outreach screening activities in ethnic minorities, both in Belgium and in Uganda. So we're very excited today to hear from Dr. Vanwolleghem, and we are very grateful to him for joining us. We invite audience members again to put any questions that you may have in the Q&A box as they arise, and they will be addressed at the conclusion of the presentation. So without further ado, we will invite Dr. Vanwolleghem to begin his presentation. This was where we were experiencing a few technical difficulties, so I will just check to see that I have received it. Just one moment, we appreciate your patience. Okay. All right, I believe that they are almost downloaded. Okay, they have successfully opened. So I will share my screen. All right, are you able to see Dr. Vanwolleghem?
Do you hear me?
Yes, thank you
Okay,
so
wonderful.
much.
Yeah. Yeah, wonderful. Can I start?
Yes, please.
Ah, sure. Okay. No, there was a bit of a problem of having the slides transferred, but now we're all set to start this this seminar. So thanks for the kind introduction, Beatrice. My name is Thomas Vanwolleghem, as presented, and I work at the University of Antwerp, and I will talk about the long-term outcomes of hepatitis delta and several public health aspects. Can I have next slide? So these are my disclosures. Next slide. So during the talk, the next 40 minutes or so, we will be discussing long-term outcomes and the impact of treatment. And I will first focus on Belgium because this is, of course, the country where I initiated my research from, but then dive into a multinational and multi-continental approaches to investigate these long-term outcomes, discussing also some aspects about Africa, then looking into the outstanding issues of genotypes of hepatitis delta and outcomes, and important aspects about the performance of delta RNA assays. And finally, we will end with public health aspects. Next slide, Seth. So this is the first study that we formally initiated more than 10 years ago, looking into the long-term outcomes of hepatitis delta in Belgium. This is a study that was published at the beginning of this year in Journal of Viral Hepatitis. Next slide. And what we did was in Belgium, we're a small country, but you can imagine, yeah, I think you can see my my pointer here. So we have a national reference center for viral hepatitis that performs confirmatory anti-delta sero studies for almost all clinical sites in Belgium, and then also the delta RNA PCR, which is only performed by the National Reference Center. Now, this gives a perfect tool in order to collect data from different sites throughout the country and to have a national representative data set. So what we did was we looked into the database from the National Reference Center, and we looked into sites that had at least 3 patients diagnosed with hepatitis delta in a time frame of around 10 plus years. And we ended up with roughly 8 centers, taking into account also the geographical spread. And as you can see here, we have the capital of our country, which is Brussels, with 3 centers. We have Antwerp, where my university is situated. We have Liège, Ghent, and Bruges included. So all large centers in our country. As inclusion criteria, we applied all patients that presented between July 2001 and January 2023 and had at least 2 visits in their center, had either surface antigen or B-DNA positivity, and either delta seropositivity or delta RNA positivity. Now, the medical chart review was performed by 3 investigators, and they filled in an electronic standardized case report form. And as a criteria for advanced liver fibrosis, we used histology, so having either a METAVIR score above 3 or liver stiffness measurement above 10.4 kilopascal, or if not available, clinical signs for cirrhosis and portal hypertension, so based on endoscopic or radiological criteria. So based on these criteria, we ended up, after exclusion of patients that only had one visit or were followed up in several centers, with 162 patients. Next slide, please. And looking into the Delta RNA at last evaluation of these patients, we had 51 patients that were Delta RNA negative, 92 patients that are Delta RNA positive, and then of 19 patients, there was no Delta RNA assay performed. And I list here the important clinical outcomes or diagnosis for each of the categories. So including having advanced fibrosis, developing liver decompensation, liver cancer, liver transplantation, or death. Next slide. And if you look at the data set regarding baseline characteristics according to Delta RNA, it's clear, first of all, that these are quite young patients. So these are patients that are roughly 36 years old, predominantly male, and representing different ethnic origins. Patients originating from Africa, Asia, but Middle East, all being cared for in Belgian centers. And it's clear that patients from European descent were more likely to be Delta RNA positive at baseline. Patients with Delta RNA positivity were also more likely to have liver test abnormalities reminiscent of severe liver disease, so higher INR and lower platelet counts. These patients also were more likely to have advanced liver fibrosis at baseline, to be seropositive for Hep C, and or co-infected with HIV. Next slide. And if you look into the characteristics of this cohort based on the presence or absence of advanced fibrosis, importantly, you can see here that the diagnosis of fibrosis was made based on histology in half of the patients. And in the other half, it was based on liver stiffness measurement or the presence of signs of cirrhosis or portal hypertension. Now, patients with advanced fibrosis were more likely to be older and again were in 70.8% roughly being Delta RNA positivity. Another point of interest was that these patients with advanced fibrosis at baseline were also more likely to be NUC experienced. And next slide. So next, I show you the occurrence of severe liver-related events. And here on the right side, you can see that a quarter of patients, 40 in total, developed at least one severe liver-related event, predominantly being ascites, but also hepatic encephalopathy, variceal bleeding. And a quarter of these patients did so already at presentation. Now, 9 patients eventually died during our roughly 10-year follow-up period. And what is clear is that if we divide patients based on either advanced liver fibrosis at baseline in Kaplan-Meier analysis or at Delta RNA positivity, that there's a significant difference in terms of outcome, being that a quarter of patients would have an outcome within 5 years if they are Delta RNA positive, and up to 40% would have an outcome within 5 years if they have advanced fibrosis at baseline. Now, this holds true for all individual liver-related events, including liver decompensation, as you can see here. Next slide. As well as liver cancer, of which 16 patients presented with cancer throughout follow-up, and 2 of them were seen with liver cancer within 2 months after presentation. And finally, 15 patients needed to be transplanted for hepatitis delta in Belgium in our national cohort study. Next slide, please. We wanted to investigate the factors associated with these severe liver-related events. And in univariate analysis, it was clear that the age of admission was associated. Several values for liver disease, lab values for liver disease severity, including the MELD score, which is the model for end-stage liver disease, including INR, bilirubin, and creatinine, being delta RNA positive, having an HIV co-infection, and advanced liver fibrosis at baseline. Now, in separate multivariate models, we analyzed the interdependencies of these several factors, and what was evident that delta RNA positivity remained independently associated with severe liver-related outcomes in all models, and separately also the age, the lab values for liver severity, liver disease severity, and advanced liver fibrosis at baseline, but not HIV co-infection. Next slide, please. In our cohort, we also wanted to examine the effect of antiviral treatment that was available in Belgium the last 20 years or so. Now, interestingly, only a quarter of our patients were exposed to interferon, 46 patients to be precise, and prior interferon exposure was associated with one death. That was one patient that was delta RNA after his or at the end of treatment, but had cirrhosis at baseline. And there were 9 patients with severe liver-related outcomes that were exposed to interferon. And after analyzing, this was not statistically significant associated with an improvement of outcomes. Similarly, we examined whether patients with a persistent virological response, and this was not available for all patients, so we defined this as being delta RNA negative after 24 weeks of end of treatment. We observed this only in 10 patients, so roughly 23-24%, which is resembling the real-world outcome and efficacy of interferon in other cohorts as well. Now, this persistent virological response, again, was not significantly associated with an improvement of severe liver-related outcomes. Importantly, NUC treatment, which was given to roughly 40% of patients, was seen more in patients with advanced fibrosis. And this is a reflection of the prevailing reimbursement criteria in Belgium, because as the audience will know, having hepatitis delta and B co-infection has an influence on the B replication, and it is required to have either high levels of HBV DNA above 2,000 international units per ml, or having a diagnosis of cirrhosis in order to profit from reimbursement for nucleoside or nucleotide analog treatment in Belgium. So it's more, in my opinion, a reflection of the reimbursement criteria than a true proof that NUC treatment is associated with advanced fibrosis, but we'll come back to that in the hidden study as well. What we especially wanted to examine, what we especially wanted to examine is the temporal effect. The temporal effect, where we analyzed the presentation of patients before 2010 and being diagnosed with hepatitis delta later on and even after 2015. And this showed that even when you were diagnosed in 2005 or so, or in 2020, the care and the treatment and the outcome of hepatitis delta was not different. So this implied to us that even for a rich country with a high GDPR per capita as Belgium, we did not improve in our treatment or and our care, and signifying that another approach and extra options for treatment are definitely needed. So can we now have the next slide? So based on this study and this initiative, we were also able to answer some of these aspects that were not clear from this smaller cohort in the Hepatitis Delta International Network. And some of our data, the data specifically from Antwerp, were included in this hidden. Next slide. So the hidden study group originally included more than 1,500 patients. That was a cross-sectional study that was published in 2018. And the initiative was taken by the colleagues from Hanover to study the long-term outcomes, and therefore questionnaires were sent to all the participating sites. 700 plus questionnaires were returned, and of these questionnaires, some patients, only a minimal, were from African origin or did not include the country of birth, and 100 plus questionnaires already had endpoints of severe liver-related endpoints at baseline, and therefore these were excluded in the analysis. So in the end, 648 patients were included, treated for in 14 centers and 11 countries. And here you can see in the world map the distribution of the different regions of origin. And what is clear is that you have the Central or South European region here as represented by CE, the Eastern European region as represented by EE, Eastern Mediterranean region represented by EM. And all these patients were being cared for mostly in European expert centers, as you can see here. And then separately, there was the South Asian region, predominantly from one center in Pakistan, and the South American region, predominantly from one center in Brazil. Next slide. If you look at the baseline characteristics from these patients, it's clear that there were quite some differences. First of all, in the South Asian region, so the Pakistan patients, these were clearly more male, while more females were present in the Eastern European regions of birth. Patients had significantly different ages. They were a bit older compared to the Belgian cases, while the Pakistan cases were more reminiscent, at least in terms of age, to the Belgian patients being 35 years or so. What was also more evident is that the Pakistan patients had a larger proportion, so were more likely to be delta RNA positive compared to all the other cohorts, and less likely to be treated with interferon at baseline, and less likely to be treated with nucleoside analogs at baseline. On the other hand, the South American patients, so the Brazilian patients, were more likely to be treated with nukes at baseline. Next slide. Now, the overall outcomes resemble what we've observed in the Belgian cohort. But first, I want to draw your attention to the overall incidence of severe outcomes. Roughly 32%, so almost 200 patients, developed a severe outcome within 4 years, with 84 patients, so 14% dying, 1/3 to be Delta-related, and 13%, 80 patients needing or requiring a transplant, developing ascites, hepatic encephalopathy, variceal bleeding, and up to 1/10 developed liver cancer during this follow-up. If you analyze these severe outcomes depending on having cirrhosis at baseline, again, it is clear that the baseline advanced fibrosis or cirrhosis is significantly associated with worse outcomes. Similar so for having a positive delta RNA during follow-up, so the last available delta RNA, if this would be positive, this shows that your outcomes are much and significantly worse. Next slide, please. Now, diving into the region and the origin-specific outcomes, it's very interesting to see that on the left-hand side, although the follow-up duration is shorter for patients from the South Asian region, these patients clearly have a much earlier endpoint, severe liver-related outcome compared to all other patients, including the patients from the Southeast, from the South America, as is here evident from the purple line. And what is not shown here is that liver transplants were more likely to be performed in patients from the Eastern Mediterranean and the Eastern European region of birth compared to other origins. And one of the analyses I like about the hidden is the specific interpretation of being a migrant or not, because this is also informative regarding several barriers to care, socioeconomic health literacy barriers. And I will show you or explain you based on this Kaplan-Meier. First, what was done here was patients that were born in the regions, so the Eastern Mediterranean, Eastern European, or South Asians, but in fact living in Central European region and taken care for by Central European sites. These patients basically had a worse outcome compared to patients that were born in the Central European region and also taken care for by these centers. So it shows that your background, your ethnic background, even if you reside and you're taken care for in the same center, informs your risk for severe outcomes. Next slide, please. And in this data set, quite some patients were exposed during follow-up at to interferon. And in this data set, it's clear that interferon-based therapy was associated with an improvement in event-free survival compared to patients that were not exposed, and vice versa. Again, what was seen is that patients that received NUCs during follow-up performed worse, or at least had a lower event-free survival compared to patients that were not exposed to NUCs. Again, this is suggestive for, let's say, the start of NUCs in patients with more advanced liver disease, for example, in the inavailability of other treatment options if patients present with decompensated liver disease. For other treatments, including bulevirtide, lonafarnib, and experimental treatments, the data set was too small to allow a robust analysis. So we are really awaiting data on the effect of especially bulevirtide on the long-term outcomes for hepatitis delta. Next slide. The previous cohort studies analyzed the occurrence of severe liver-related outcomes, so really the clinical endpoint. But one of the outstanding issues is, and I've shown you the heterogeneity of the disease presentation and the evolution depending on your region of birth, is also whether we can identify cohorts or markers that are associated with fibrosis progression. And this is an ongoing study that was initiated by several investigators from in Europe, but is currently being further analyzed and led by Sabela Lenz from Barcelona. And then it includes patients from Spain, several hospitals, from Italy, Greece, France, Belgium, which is our cohort, and the Swedish cohort. And what we did is, next slide. We really wanted to focus on the factors associated with fibrosis progression, and therefore we specifically included patients that were delta RNA positive at last evaluation that did not have advanced fibrosis at baseline. Advanced fibrosis here in this cohort was defined again as being as having a liver biopsy with Metavir above F3, or having a liver stiffness measurement above equal or above to 10 kilopascal. And we had 177 patients. Half of them were female. They were pretty young, 38 years. Some of them were obese, had diabetes. A fraction was seropositive for Hep C, and a liver biopsy was available in half of them. And the mean liver stiffness measurement was 7.7 as per the inclusion criteria of our study. Importantly, we had regarding the ethnic distribution or background, we had a quite good distribution with a predominant 50% representation of Caucasian patients, a quarter Asian, and another quarter Sub-Saharan patients. Next slide. Now, this is ongoing study, has not been published yet, but was presented at the hidden meeting in Amsterdam by Sabila Lenz. And during follow-up in this data set within 5 years, although patients did not have advanced fibrosis at baseline, 40 of them developed cirrhosis, and 5 developed liver decompensation and other clinical endpoints like HCC, liver transplantation, and even liver-related death. So in an analysis for factors associated with cirrhosis development, it was clear that in a multivariate analysis, patients with a baseline liver stiffness measurement above 7 kilopascal, as well as having lower platelet counts and lower albumin levels, were associated with the development of liver cirrhosis during follow-up. Next slide. And importantly, in Kaplan-Meier analysis, it's clear that patients with baseline liver elastography below 7 kilopascal were protected from cirrhosis development according to our cutoffs for the next 5 years or so. So clearly, this data set would allow, if confirmed, to identify patients upfront in need for urgent treatment in order to prevent liver disease progression. Next slide. Now, what about Africa? It's clear that Africa, and this is a study from the annual mortality published in 2015, that Africa is disproportionately affected in terms of annual mortality, both regarding HIV, but also regarding HBV, especially if we compare the mortality to the Europe subcontinent and the Americas. And nevertheless, Africa is clearly underrepresented for clinical trials towards the suppression or the functional cure for hepatitis B, and even more so for hepatitis delta, for which there's almost no natural history data available. Next slide. Although there's one, and I like this study, one prospective study that was coordinated by the group from Vanwolleghem, performed in the Gambia, and this group included patients that presented either with HCC, so roughly 250 patients, or with cirrhosis without HCC. And they were then followed up for 24 months. And what is clear from this study, first, most of these patients had chronic viral hepatitis. They were seropositive for surface antigen in 62%. 10% were seropositive for Hep C, and another 10% also had exposure to hepatitis delta. But what is really troublesome here in this data set is that the median survival after a diagnosis of HCC is really short, only 1.5 months. And this data has also been confirmed in other large data sets for the median survival for having liver cancer in Africa. Even if you are diagnosed with cirrhosis, the median survival is less than 2 years. Next slide. There was, however, one optimistic or positive news of this trial, in that patients that presented with compensated cirrhosis were offered VIRIA treatment. And they were followed up during these 24 months. And in total, 56 patients were proposed VIRIA treatment, but only 31 came back and started treatment within these 4 or 5 months after initial presentation. Another 25 patients were offered treatment but never returned and were not retained in care, but could be reached by phone for survival data. And this allowed to analyze basically the effect of initiating TDF treatment upon diagnosis in patients with cirrhosis in Africa. Due to hepatitis B. And what you can see is that initiating TDF allows to improve survival. So this study really calls for active screening and TDF treatment initiation as soon as the diagnosis of cirrhosis is withheld, and this independent from viral load or other diagnostics. Next slide. Now, this was a study from Eastern Africa, and we've been involved together with Ponciano Ochama from Makerere University in Uganda in studies with Ponciano for hepatitis B, mother-to-child transmission, and HCC screening. And based on the initiative from Ponciano, who originally did his PhD in the University of Antwerp, and this is a picture of his promoter, who is now an emeritus professor, but he also supervised me during my clinical training in internal medicine. So we are now collaborating with Ponciano to study the long-term consequences for hepatitis delta in Uganda, and this is a project that Dr. Sarah Kane Sibirwa will be coordinating under the supervision of Ponciano, but also from Professor Kirk at Johns Hopkins and myself. And we will look into 2 cohorts, mainly HIV cohort that was recruited from the Infectious Disease Institute in Makerere and followed for 5 years, and an 800 participants, a large cohort of which a part is infected with HBV only and another part has a co-infection with HBV and HIV. So we expect the results within 3 years or so, and I'm really looking forward to build further the evidence on the impact of hepatitis delta in Africa. Next slide. So to conclude these several natural history studies, it is clear that collaboration with different centers, different countries, and different continents is indeed necessary in order to build and expand the knowledge on the consequences of hepatitis delta, and especially regarding factors that are associated with liver disease progression, severe liver-related outcomes, and overall outcomes. And these data show that patients that are remaining delta RNA positive, those with advanced fibrosis at baseline, are associated with severe outcomes, that the region of birth also influences the outcome, and this shows the clinical heterogeneity of the disease, where the question still remains, is it the virus or the host or a combination? So what is the effect of the viral genotype? And we'll dive into that immediately. But clearly also the migrant status is important, showing that your background and your availability or the barriers that exist in terms of access to care are determining your outcomes. For it seems that FibroScan would be able to help us in identifying patients in need for urgent treatment, and these data require further exploration and further validation. And as for now, interferon treatment is associated with an incremental improvement in outcomes, but not a big breakthrough improvement that we hope for. And it's clear that we need other treatments and data showing that other treatments are associated with improvements in long-term outcomes. And what is clear is that nuke treatment apparently does not improve these outcomes. And I hope to have shown you that Africa is really underrepresented and that we really need to focus more on Africa. Next slide. Now, I've already explained you that there's a heterogeneity in the clinical presentation and the progression determining or based on the region of birth. And next slide. And the question whether the host or the virus determines these outcomes is still outstanding. And the reason is that it's not so easy to perform these genotyping studies. And one of the most renowned lab in this respect is the lab of the French reference lab with Frédéric Legal, amongst others, who collected more than 2,000 Delta strains between 2001 and 2014 and analyzed a 400 stretch base pair length of the coding region of Delta, of the Delta protein. And in 100 plus strains did a full length sequencing. And they were able to show that, in fact, there are 8 genotypes for hepatitis delta based on a similarity of at least 80%. And what you see in the world map here is that hepatitis delta genotype 1 is clearly dominant. You see that genotype 1 is present in the Americas, but also Europe, Asia, part of North, East and South Africa, as well as Australia. And then there's pockets that clearly have a more diverse genotype. For example, the Amazon basin, where Delta genotype 3 is very prevalent. You have Central Africa and East Africa, where 4 different genotypes circulate, with genotype 5, 6, 7, and 8. And then genotype 2 can be found in Taiwan as well as in Siberia, and genotype 4 is more present in Japan. Now, having said that, it's true that genotype 1 is present throughout the world, but subtypes of genotype 1 are more clustered. For example, genotype 1D is more present in North America and Europe and Central Asia, while 1B, 1A is more present in Africa. Next slide. Now, the studies on the association of genotype and outcomes, as having said that the assay is not easy to be performed and is not commercially available, there's not a lot of data available as well. And one of the nice studies out there is the French study making, so in collaboration with the French National Reference Lab, where they studied the outcome of more than 1,000 patients, of which roughly 90% were Delta RNA positive. And you can see that half of these patients were from sub-Saharan African descent, and the other half being either from Asian or European or North African descent. And 3/4 of all patients were infected with genotype 1, while the remaining were infected with genotype 5, 7, 6, and 8, especially those originating from sub-Saharan Africa. And during their follow-up study, which spanned over 10 years, it was clear, and this was really novel, that patients originating from Africa performed or fared better compared to patients infected with genotype 1 without an African background. So even patients with an African background infected with genotype 1, as you can see here in the gray scale, have a significantly lower incidence of cirrhosis. So pinpointing to the fact that genotype or subgenotype, but also possibly ethnic background informs your outcomes. Next slide. And this was the first study, but in the same issue, or almost had back-to-back in the Journal of Hepatology, a single center study from King's College was published, analyzing their outcomes in 50 or so patients being delta RNA positive, of which half were infected with genotype 1 and the other half infected with genotype 5. And what you can see is that throughout follow-up, patients infected with genotype 5, so per definition, the East or Central African patients performed well and did not decompensate, while patients infected with genotype 1 decompensated within 15 months or so. Again, analyzing the data set based on the ethnicity, you saw that patients from African descent had an event-free survival that was significantly better compared to patients from Europe and Asia. Next slide. Having said that and identified the difficulties in performing these genotypes, it is also important to stress the different assays that are available. And again, the French did this important study of coordinating an interlab validation by sending around 20 samples which contained different genotypes and different viral loads, and also the WHO standard, which is available since 10 years or so. And what you can see here is that all these different 28 labs had to quantify and measure the delta RNA, and the gray scale represents the positivity rate of the sample. So you can see quite some white cells here, and these white cells are more there or present in samples that are originating from African genotypes, and being genotype 1 or 5, 6, 7. So for the European samples, it seems that the labs were able to detect roughly all viral loads. Next slide. Now, this was a study in 2016 or 17 of mostly in-house assay, but importantly, a very recent study published in 2024 analyzed the positivity of your delta RNA assay based on the use of 2 different kits. So this was a study, a longitudinal study of samples at baseline or throughout bulevirtide treatment. And what you can see is that not only the quantitative value, but also the positivity, so being positive or undetectable, depended on which type of assay that was used. Next slide. So this, to conclude this part, it's clear that long-term outcomes of delta are heterogeneous and differ according to baseline ethnicity, but also genotype. But having said that, the RNA assays that are essential to perform this type of studies show substantial variability. And this is not only true for in-house assays, but also for commercial assays, both regarding the determination of the genotype and the sensitivity depending on the genotype, but also for the quantification. Despite this, we have luckily a WHO standard available since 10 years, which allows for interlab comparisons. Next slide. Now, to conclude, I want to highlight some important aspects that have been identified and come out of these long-term follow-up studies, and also the delta RNA assays that are available. And this is based on a viral hepatitis prevention board meeting that was held in 2021. Next slide. and of which all the conclusions and the challenges have been published in a paper in your journal Viral Hepatitis. So during this 2-day meeting, several European experts gathered, and this was during the COVID crisis. So this was an online meeting, but was well participated, and we identified several aspects regarding hepatitis delta that needed attention. So one of the, and these are listed here, but can be found back in the publication as well. So clearly, finding biomarkers of progression of infection, so not only the fibroscan, but the other biomarkers, in order to identify patients that are in urgent need of treatment, so before they develop a severe liver-related complication. Similarly, the natural history of hepatitis delta is still not completely known. We are still dependent on retrospective, multi-country, multi-continental studies, and the attributable risk, for example, for cirrhosis and hepatocellular carcinoma still needs to be defined. There's an urgent need for sera and reference materials to improve the diagnostic assays in between labs. We would need better tools for staging of liver fibrosis, because liver elastography is skewed in patients with ongoing liver inflammation. The clinical trials that are ongoing are really needed, and we need to have new treatments that are available throughout the world and especially affordable. We need to have good virological endpoints that predict the long-term clinical outcomes. And in parallel, we need to know good treatment endpoints at which we can stop treatment. And ideally, we would have an alternative to subcutaneous bulevirtide injections, like oral formulations, for example. Next slide. And having said that, what was clearly mentioned in that meeting is that it is our role as health professionals, but also as clinicians and also as patients, to increase awareness and to improve the advocacy of hepatitis delta. And I show here in the left upper corner that hepatitis delta virus is now, since this year, recognized as a rare liver disease. And we pushed hard to have this on the agenda, because in the past, the European reference networks for rare liver diseases were mostly focused on genetic liver diseases and less so on infectious diseases. But having this disease recognized as being rare will help in convincing our policymakers of investing more in hepatitis delta, especially, and this is something that I'm almost afraid to tell, but especially as in Belgium, the bulevirtide is not reimbursed yet. And I hope we can change this soon, despite all the efforts that have been done yet. So other aspects that are there is that these patients, that as I've shown you, are often from poor socioeconomic backgrounds and are therefore less vocal and less eloquent compared, for example, to the European HIV positive patients. They have not only the stigma of HBV, but also combined with hepatitis delta. And there's not enough knowledge and awareness in different stakeholders, not only the general population, but also the health professionals, the clinicians, and the policymakers. So it's our task to shout out for advocacy, to improve the education, and improve and advance public health and clinical research, but also publish this data in order to change this important outcomes. So thanks a lot. Next slide. These are my acknowledgements. So the research that I've shown is largely in part because of the effort of a lot of people, not in the least the people from the viral hepatitis research group, which I'm leading at the University of Antwerp. So there's Arno, Erwin, and Lisbeth, and also other PhD students like Axel, Tom, who's a postdoc, Fleur, and Marie. And then we collaborate with the Viral Hepatitis Prevention Board, also at the University of Antwerp, with the National Institute, with people from HIDIN and the European Delta Fibrosis Study Group. And I'd like to also acknowledge my funding for allowing these type of studies. And I'm happy to take any questions. Thank you.
Thank you so much, Dr. Vanwolleghem. We really appreciate this presentation and how comprehensive it was, and especially, speaking about the needs for more consistent testing practices and the public health, the need to incorporate hepatitis delta more into public health outcomes. So I think we are a little over time, but we do have some questions from the audience. So we have one from Dr. Fofana, who says that this webinar is timely, especially for hepatitis B endemic countries. However, we do face real problems with diagnostic tools for hepatitis delta, not only for serology, but specifically for access to viral load testing and RNA. I think this is in sub-Saharan Africa specifically, and access to FibroScan is also problematic. So how can we, with limited resources, gain access to the tools in order to provide Delta and improve Delta diagnostics and patient care?
Yeah, I think this is a very relevant question, and there's no easy answer, I'm afraid. If not, we would probably have solved it already. Regarding the FibroScan tools, I do think that these are more flexible in terms of availability. Also in sub-Saharan Africa, we do have some liver elastography measurements and tools that can be easily shipped out and even be handheld. And there's quite some institutes like, for example, Makerere in Uganda that has access to these FibroScans. What is more difficult is, of course, the delta RNA assays, and that's really a roadblock that we need to resolve, because also in the high-end European labs, there are clearly different difficulties that are still out there, as I have shown, and I think that the community needs to work at large in order to find solutions, ideally in-house assays. And I know there are some initiatives on that part by the French Reference Lab that make available the tools and the PCR primers for, let's say, less developed labs that still perform well, especially also for African strains.
Great. Thank you so much. That's great to hear about, some promising advances. We also have another question. So thank you for this insightful overview. Considering the WHO and ECDC have set forth hepatitis B and C elimination targets, do you think that hepatitis delta should be a separate target as well in respect to co-infection with hepatitis B? And if so, what would that target be, especially related to outreach and screening and baseline burden of disease or potentially reflex testing programs?
Yes, that's a very good point. At the last VHPB meeting, we especially mentioned this as well. We wanted to have Delta included in the updated WHO elimination guidelines. And one of the advantages is, of course, that having the HBV vaccine, which also protects against Delta, so against chronic HBV and chronic Delta, is one of the biggest assets at the public health level available. So it would make sense to include Delta in the or elimination goals by focusing on in the first place on vaccination coverage. And I'm afraid to say that, for example, in sub-Saharan Africa, there's still shortage of bird dose vaccines, and I think that this is really, from a cost-effective point of view, the most evident first step that we should take in trying to reach a 95 plus coverage of bird dose vaccines, and this would evidently also result in let's say health profits later on. Regarding treatment, I do hope that treatments will be available throughout the world, but I have to say that even for the nucleotide analogs, these are not available for sub-Saharan Africa. So I think we have to leverage the experience of HIV and HIV treatment centers there in order to combine care for HIV, because this infrastructure is well developed, and to combine care for HIV with HBV and eventually also with hepatitis delta.
Yeah, absolutely. I know integration efforts are very crucial for sure. So thank you so much for your answer and for the great question. We do have one more question. So this participant is from Canada, who says that even there, it is very difficult to get hepatitis delta testing and viral load testing. So is there any hope that the rare disease designation will help to address some of these limitations?
Well, I'm not absolutely sure whether in Canada the same structure exists as in the European Union, where the rare liver disease network is a powerful tool to approach our own government and to convince them. But I do think that clinicians in each of the countries should push for having Delta RNA assays available, minimally in a national reference center, but hopefully also in other sites. And there's some commercial assays available. So the question raises, of course, whether these will be intercomparable. But I think, again, it is up to the clinicians here to raise awareness and to speak out and to reach out to their respective stakeholders, I think.
Yeah, absolutely. And then one final question I had, I was interested in, you touched on many interesting points, but in particular, how migrants, even in the same settings as their native-born counterparts, have difficulty accessing care. So just any thoughts on how that can be, the roles of different stakeholders and how that can be remedied? I know it's a complicated problem, but any ideas?
It's a complicated problem, and it's one of my interests here in Belgium as well, because we are performing outreach screenings, and this is where I really believe that we can make a difference. So what we do in Belgium is we reach out, so we go into the field. A researcher of my team screens patients at citizenship classes, gives some information about the organization of the healthcare structure in Belgium, for example, and then offers a free of charge a test for hepatitis B. And if positive, then they are referred for a first free consultation at our unit. And what we see, for example, we've seen quite some Delta positive Afghan refugees, so people that moved from Afghanistan to Belgium. And this succeeds in a good linkage to care, and allows also to have some community workers involved that know the language, the barriers, the cultural barriers. So I do believe that organizing these outreaches is the first step in order to link these patients to care and to have an early diagnosis.
That's fantastic. I'm so glad to hear that that type of work is being done and can hopefully be replicated elsewhere as well. So, um, well, thank you so much. This has been a tremendous presentation. We really appreciate your time. I know we've gone a little over time, but so thank you everyone also for attending today. I will just go through our last few slides. Shreya, do you mind just screen sharing the closing slides, please and thank you. So again, we really appreciate the time and insights of our excellent speaker today. So thank you so much again for this great presentation and for everyone who attended. Apologies again for technical difficulties, but thank you for hanging in, and we hope that you found it informative and valuable and can use some of these learnings from your life or work. We encourage you to complete the evaluation form when the webinar concludes. And again, a recording of this webinar will also be emailed out to all registrants. And we also encourage you to sign up for our newsletters that we have. We have one for hepatitis delta providers and another for those living with hepatitis delta. And by being added to these mailing lists, you'll receive regular updates about hepatitis delta drug developments, clinical trials, research, news, and events like this one. So you can find the links to sign up for each of these newsletters in the chat, and they will also be emailed out after the presentation as well. So also please do feel free to reach out and get in touch with us using any of the contact information listed on the slide, and visit our website for more information. And we thank you so much again to Dr. Vanwolleghem and to all attendees for today's webinar, and really appreciate your time. Have a wonderful rest of the afternoon and evening.